So I'm a medical oncologist. I spend my time taking care of patients with sarcoma and chordoma, and then probably half of my effort is running clinical trials. So I've been tasked today to talk to you about some of the medical therapies we use for this disease. And I promise not to show any pictures from the operating room. So I don't know if that was too graphic for anyone. So just a brief outline. We're going to talk a little bit about some of the challenges we face in this disease. I'll give you a quick primer on some of the different classes of medical therapies we might use. And then I want to spend a few minutes talking about clinical trials because I think this is extremely important for this disease. And then I'll give you an example roadmap of how I approach my approach to patients with metastatic or recurrent chordoma from a medical oncology standpoint. Now, most of what I'm going to cover today is really geared at patients with, like I said, metastatic or recurrent chordoma, but our real goal here is to find a drug that's so potent and so well tolerated that we can even give this before surgery, before radiation, and perhaps reduce the morbidity of those treatments. All right, so let's talk about the challenges. So this is a very different disease than other cancers. So we're talking about hundreds of cases per year. So think about it in comparison to like breast cancer, prostate cancer, lung cancer, hundreds of thousands of cases. So when you're trying to study a disease with so few cases, it's really hard to run these clinical trials to really know the natural history of this disease. And moreover, we have subsets within this disease. So there's conventional chordoma, but there's these less common, poorly differentiated and dedifferentiated subtypes. And within these, there's a very heterogeneous clinical behavior. What do I mean by that? Some patients will have metastatic disease, but it may only grow by millimeters per year, whereas others can get very sick very quickly. So you might imagine a scenario if you run a clinical trial, you may inadvertently recruit a bunch of patients with sort of more indolent disease, slow-growing disease, just because they're healthier, they're able to participate in the trials. You may falsely conclude that your drug's working, when in reality, that's the natural history of the drug. So it's really important to keep that in mind. And then this is a little harder to conceptualize, but interestingly, there's a defined known subset of, we have 30,000 genes in our body. Of those, probably 1,000 are important for cancer that we know about. In other cancers, other carcinomas, non-chordoma, there's patterns. There's certain programs that are turned on within those different cancers, and drugs are being developed for those. There's a lot of money being put into lung cancer, colon cancer, things like that. We actually lack those targets in chordoma. They're just not there. It's a different biology that drives that tumor. So it's very hard to take drugs that work in one disease and bring them over to chordoma. All right, so let's go through some of the options for treatment. We heard a little bit about observation earlier. So what is that? So as I mentioned, some patients may have very slowly growing tumors where we get scans, and after 3 months, after 6 months, after 12 months, it may only grow a few millimeters per year despite having metastasized to the lungs. So in that scenario, you actually might be able to watch somebody for some period of time. If it's small tumors, small micrometastases, unlikely to cause symptoms, be a problem. So I'll often try to answer that question first and maybe actually just follow somebody with surveillance and see how it goes. You've probably heard a bit about targeted therapies or small molecule inhibitors is sort of the names we use for these. So these are drugs that actually are designed to target particular proteins of interest. So in every cell in your body, you have the same set of DNA, right? So the same genes are in every cell, but different genes are turned on to make a skin cell, a muscle cell, things like that. And as that DNA is copied, mistakes can happen, or through external insults, there can be mutations, solar radiation, chemicals, things like that. And a mutation will happen, and there's actually this army of 400 or so proteins whose job it is to find these mutations, try to repair them, and if it can't be repaired, kill that cell. But every now and then, something sneaks by, and that creates this abnormal protein that's driving this cancer, telling it to grow when it shouldn't grow, live when it shouldn't live. And what can we do about that? So a targeted therapy, the idea is to find a drug that can bind that abnormal protein and shut it off and stop that cancer from growing. So it's a pretty cool concept and certainly been validated in many other cancers. What about immunotherapy? This has made a lot of headlines in the last 10 years. So your immune system is a really important system whose job it is to look for infections and stop them to keep you safe from the outside world. And your white blood cells, your T cells and B cells are sort of the soldiers of the immune system. Their job is to look for infection, but another really important job is to look for abnormal cells. So these could be cells that are infected with a virus, or they could be a cancer cell. And we actually have these gas pedals and brakes for this system. So gas pedals, it makes sense. You want to push this reaction forward so you can recognize an infection, recognize a cancer cell and learn about it and kill it. but also breaks, right? Because we don't want the immune system to go haywire and then cause an autoimmune problem. So if you know anybody with like lupus or Crohn's or rheumatoid arthritis, these are autoimmune problems where the body's actually attacking itself. So these gas pedals and brakes are in perfect harmony to try to make sure you're safe. So a dirty trick that many cancers have figured out is they actually can hijack that system, the brake system, and say, hey, don't attack me, I'm normal, when they're not. And they escape what's called immune surveillance. So this blockbuster field of drugs has been developed to sort of take the brakes off the immune system to let it attack the cancer. And it's really made amazing strides in things like lung cancer, head and neck cancer, bladder cancer, things like that. And we hope that someday it'll be important for chordoma as well. So those are the brakes. There's also gas pedals. So what are we talking about there? So these might be something like a cancer vaccine study. So we've seen a few of these go through the chordoma world, more to come, hopefully. And then also some that will take these T cells out of your body, engineer them to recognize a protein in some tumors, and then give it back to you, which is pretty incredible technology. We'll come back to clinical trials. Let's talk briefly about chemotherapy. So what is chemotherapy? So these are drugs that are designed to target DNA itself. So they've been around for decades. And many of them will actually bind DNA and block its functions. So it can stop it from turning those genes on to make them abnormal proteins, or it can even, in some cases, cause DNA to break. And the hope here is that the cancer cells are more sensitive to the chemo than, say, a normal cell. But these are very toxic. That's why, if anybody knows anybody who's been on chemotherapy, they often can be quite sick. And that's because we're hitting a lot of off-target normal cells in addition to the cancer cells. Chordoma is generally, at least conventional chordoma, chemotherapy resistant, but there are scenarios we will use it. I may be in the minority on that, but I think there are cases where it can be very important and very valuable tool in our kit. All right, so let's transition to clinical trials. So this is a bit of a bigger topic. The goal of clinical trials are to develop new therapies for diseases. And this is particularly important for ultra-rare diseases like chordoma, where we need more drugs in our armamentarium to go after this disease. So this is a sort of a schematic of the course of a drug that it goes from its infancy to FDA approval. So this is a really complicated topic. We could spend a long time on this, but we won't. But in the initial conception of a drug, it starts in the preclinical work, so before it gets into people. So work in the lab, where somebody finds a drug that hits a target that may be important for a cancer. If this passes the bar to get into the clinical trials, we start with these very controlled studies called phase 1, phase 2, and phase 3. They're highly regulated to show that this drug actually works in treating cancer. So phase 1 is our first in human study, so the first time a drug actually gets into people. And so in these studies, we're really asking the question, is this drug safe? What's the right dose? But in parallel, we're also trying to get a signal that this actually works and can be useful for treating cancer. Phase 1 studies are very complicated. There's a lot of visits. We're measuring the level of the drug in the patient. We're doing things like biopsies to make sure we can hit the target we want to hit. And often they include any type of cancer. So it's very few phase 1 studies will be restricted to one type. So there could be patients with colon cancer, lung cancer, chordoma, what have you. Usually with some marker that says this drug makes sense to treat in this to try in this population. As we move out of phase 1 into phase 2 and phase 3, we're now asking a different question. We're treating the same type of patients or patients with the same mutation with the dose that we found in phase 1, and now we're really trying to see does it work versus some control. For phase 2, it's typically a historical control. How does this drug work compared to other studies we've done in the past? For phase 3, it's actually comparing to either some standard of care or sometimes a placebo. So for chordoma patients, we really live in this phase 1 and phase 2 world. It's uncommon enough of a disease that we're pretty unlikely that we'll enter into a phase 3 study. But that's okay. We can still find treatments this way. So just thinking broadly about how chordoma type studies may open. So one may be that work through the Chordoma Foundation, we find some target in some of the models that we have, and Dan let somebody like me know, and then we'll try to shop the idea around to different pharmaceutical companies to get access to a drug. And then we might run a small phase 2 study where we try that drug in patients with chordoma. The other route is through phase 1. So these, again, are new drugs that are being tried in patients where they'll take any type of cancer. And so if we find in somebody's genetic testing a marker that might say this drug may work for them, or through work in the lab, we have some new target that we think we need to explore, then we can often get our chordoma patients into these phase 1 studies. Okay? All right, so what happens if you sign on for a clinical trial? So the first step is something called informed consent. So this is when you'll meet with your oncologist and they'll hand you this 20 to 30 page document that's written in non-medical language, but it still can be kind of complicated. But in that document is everything you need to know about the trial from the patient standpoint. Why is it being done? Who's funding it? What are the potential side effects? What's expected of you? What's expected of us? And the point here is for you to have a give and take conversation with your oncologist to really figure out if this is right for you. If you read through the document, you're like, hey, you know what, doc, this isn't for me, that's okay. You know, the oncologist is still gonna be your oncologist. If it's right and you decide to move forward, then you sign on the dotted line. The next step is something called screening. This is where we make sure you're eligible for the trial, so extra blood tests, EKGs, sometimes ultrasounds of the heart, new scans, things like that. And then the trial initiates. And these could be any number of different requirements once the trial starts. It could be a pill, it could be an IV medication, things like that. In general, as long as the drug is working and you're not having bad side effects, you would stay on the drug. If it stops working or you start having bad side effects, then you might come off. So the key points here that I want to highlight is informed consent. So you're not a guinea pig. People always ask me that, like, you know, you get a choice in this, right? You know, a guinea pig doesn't get a choice. It's unlikely for a chordoma patient that you will receive a placebo, so you're going to get the drug. Early phase studies, this phase 1 world, very complicated, lots of visits, blood draws, sometimes some biopsies, but you get access to this cutting edge technology of drug development. And then these later phase studies, we have more experience with the drug. They're less busy and more like you might see your oncologist maybe every 3 weeks or every 4 weeks or something like that instead. All right. So I think we're doing okay on time. So let me take you through my approach to a new patient with chordoma. Now, this may be very different than if you see a different oncologist who specializes in chordoma. There's a lot of different style approaches to this. So, you know, you can kind of take what you want from this, but, you know, you may have a different experience with some of the other docs who treat this disease. So my first question is, do we have the right disease, right? So we need to look at the pathology, because believe it or not, there's not a lot of pathologists that specialize in chordoma. So it's super important to have somebody who knows what they're doing look at this pathology specimen to make sure it's the right disease. Often we know that is the case, but you know, in the 10 years I've been doing this, I can think of 3 or 4 times where the diagnosis has actually changed. So important to do that. Most of us will recommend seeing a chordoma expert medical oncologist at least once. There's a lot of restrictions around telehealth, which is a big deal right now. But even if geographically you cannot get your care with a chordoma specialist, you can still see your local oncologist, and that local oncologist can talk to one of us, and we can kind of help out as best we can. And then I often will perform genetic testing of the tumor. So this is not looking for genes that you were born with. This is looking for genes that are mutated within the chordoma cell. I'd say more often than not, we do not find something that we can act on, but it's important for those rare cases where we do find something that we can use that to kind of guide our choice of either clinical trials or medications. All right, so the first branch point is the type of chordoma. So thinking about poorly differentiated or dedifferentiated chordoma, these tend to be a little more aggressive than conventional chordoma. And interestingly, they are chemotherapy sensitive, at least initially, so very, very different than conventional chordoma. And that's the first line treatment that most of us would recommend for this disease. I think there's an interesting immunotherapy signal there as well, so we'll have to see how that pans out. Again, very hard to know because we can't run these big clinical trials with poorly differentiated or dedifferentiated chordoma. They're just too rare. But occasionally we will find trials that poorly differentiated chordoma patients can participate in, and I think it's really important when those are available to participate. Those trials were really based on some of the genetic findings around this disease and may include different kinds of cancers that have that same mutation. All right, what about conventional chordoma? So as I mentioned earlier, for some patients we can get away with observation. If their tumor is only growing by a few millimeters per year, not causing any symptoms, then let's take some time and watch this and see what the pace of disease is. I've had some people where we've gone years and years and years without having to start something, which is pretty remarkable for them. Not the case for everybody, so it's important if the strategy is taken to really have a close eye on the tumor and get interval scans to make sure nothing bad is potentially happening. Eventually, you'll be faced with the time to choose your first therapy. And for me, the first question is there a clinical trial? I know we can use some of those other therapies off-label that we can get from other cancers, that are approved for other cancers, but I think really this is our opportunity to explore new medications that may work and may help the field. These may be specific for chordoma, so there's a handful of studies that are just looking for chordoma patients. That does mean some people might have to travel to participate, but it's important to at least consider that if the resources are there. And then going back to this phase 1 first-in-human studies, where we can take any kind of cancer, if we have a marker on the sequencing or some marker from the work in Dan's lab that looks important for chordoma, then I want to try to get those patients on that study if we can, because it's really important to get access to that. If we do not have a trial, what's next? So our therapies at this point are largely empiric, where we're going to try the different drugs that we have available. Hopefully, we'll see something on the genetic testing that may give us a signal that one drug may be worth trying first over the other. But we'll try the various small molecule inhibitors that I mentioned, perhaps some immunotherapy, and then in rare cases, chemotherapy if somebody's having a more aggressive course or their tumor is very symptomatic. And then this process repeats. So we go back to the front, and then we go again and again and again. And the hope is that you're going to bounce from one treatment to the next. So you may be able to observe for 2 years, and then finally we have to pull the trigger and try something. We may try a trial that we have available. Maybe that is a winner, maybe it's a loser. Then we try something else, and the hope is that these stretch to a long period together of good disease control, good symptom. And then the dream is that we buy our time until we find that next therapy, right? The next therapy that's really going to be the game changer that we're all shooting for. So why don't I stop there? And happy to answer any questions people might have with the Q&A session.